Good evening, everybody, and welcome to tonight's lecture of distinction on lower leg amputations, including the foot, by Paul Cooke, as part of our Lectures of Distinction series from BOFAS. A couple of housekeeping things before we start. If you could kindly use the Q&A button at the bottom of your Zoom screen to ask any questions that occur throughout the evening. I will forward these then on to the speaker, Mr. Cooke, later on at the end of the lecture. Please also open your chat function, as in it will appear, and may have done so already from Joe, the feedback code for tonight. I recommend you write this down because this is going to be your access into getting the CPD points and getting your appraisal points by giving feedback through the email that we sent to you in time to come. So tonight's lecture is on amputations. And of course, as part of the things that we do in foot and ankle surgery, of course, that sometimes it is necessary to consider this and actually then convert it into looking at it in such a positive way in so many circumstances. And I am delighted to introduce Mr. Paul Cooke, who is one of the pioneers of modern foot and ankle surgery, both in the UK and also teaching abroad. He was a consultant in Oxford until very recently and continues to be a very strong educationalist. And it's on this very subject of amputations that he's taught before, and I was very privileged to be with him in Ethiopia when we were teaching out there, and I heard him speak so eruditely on this subject. So without further ado, I'd like to hand you over to Mr. Paul Cooke.
Hi, I hope you can all hear me well. We're
Yes.
talking about amputations and disarticulations, which is when you go through a joint, in the foot and the lower leg tonight. And this is the cruelest and yet the kindest of operations that we ever perform. The role of a surgeon is slightly different in this because we tend to act as the person who decides on the amputation, but then we hand over the patient to a multidisciplinary team later for the aftercare. It's a worldwide procedure, and it's one that brings humility to us all when we amputate our own patients. So why am I talking about it? Well, my background is that I trained for a couple of years as a registrar in vascular surgery down in Plymouth in the 1980s, when smoking was almost de rigueur. And certainly all the vascular surgeons I ever trained with smoked, and we amputated quite a lot of limbs there. I then spent 30 years working in Oxford in a hospital with a regional limb fitting centre. I saw the rise of diabetes, and then about 10 years ago, the Afghan crisis started, and they asked me to go from Oxford to Headley Court twice a month to be the surgeon at the complex foot clinic, and that involved a lot of, sometimes multiple amputations in young people, which was a shocking time of my life. And at that time, I was amputating about 30 amputations a year. So why do we amputate? We amputate to relieve bad symptoms, to remove non-viable tissue, to preserve life, and sometimes to improve function. And sometimes we do it for social and economic reasons. And in Headley Court, we had a perverse incentive to start with, is that actually if you had one leg amputated, you got a pension forever and a lump sum. And if you had two amputated, you were pretty much set up for life, although the rules changed so that reconstructed feet were compensated in the same way. But it behoves each of us to think actually what we would do if we had what is now known as a tiger, where you take your car off the road, you get your bilateral severe compound fractures, and whether we really, for social reasons, would put ourselves out of action for a year or two with the financial and the professional implications of that, or whether we would face amputation. So in a nutshell, we do surgery for amputation for three reasons: for dead tissues, for dying tissues, and damn nuisance. And we probably ought to add the fourth D, which of course is diabetes, which incorporates all of these. And for exam purposes, we've got a list here of indications, congenital and acquired, like you need for every exam. But in reality, the indications for amputation in the United Kingdom are increasingly diabetic complications and happily decreasingly vascular complications. There's still some tumours, there's still some trauma. And nearly 70% of the patients were diabetics, smokers, or both. And the picture at the bottom just reminds us of why we get such massive differences in outcomes, because there's a massive difference in the outcome of this chap who's got multiple problems of diabetes, including his weight, and that of a soldier who has had his leg amputated. So just a quick note, because it's the major reason now about diabetics, the number of amputations per year in the US is huge. And so one amputation every 30 seconds worldwide. It usually comes because of a combination of neuropathy and diabetes. The lifetime risk of a type 2 diabetic who is under hospital care is 25%. And if you have your leg amputated, there's a 25% chance you'll have the other leg amputated within 2 years. And almost all of these follow an ulcer. And if NICE 2015 and NICE 2019 were adhered to, in general practice and in hospitals, about 80% would be prevented. It's different if you go to different parts of the world, and the types of amputation as well as the reasons are different. And before Tim and I, along with Rick Brown, went off to Ethiopia a couple of years ago now, I looked at papers from there, and there's a wide variety looking at in 2002 and to a certain extent in 2018 papers. It shows a lot of this is neglect. So it's the person who's had a compound fracture who takes 2 or 3 weeks in the bush until pus starts pouring out, and then 2 or 3 weeks at the local hospital before being transferred, and who is hopeless. And there are bone setters in the villages in Ethiopia, and they account for the children with gangrene after these traditional constrictive splints. But with time in the underdeveloped countries, unfortunately, smoking is still rampant and diabetes is increasing. But most of the amputations, both in the UK and in Ethiopia, could be avoided by medical changes. So when should we amputate in any given patient? Because we're going to talk about principles first and then do a Cook's tour around the foot of different amputations. We should amputate when the condition is stable. The patient might actually survive if you treat their sepsis first. Only twice in my life, I think, have I ever had to amputate to save life for disseminated intravascular coagulation in patients who are septic. In the developed world, we have the ability to send patients to see the limb amputation surgeons before and to get them physically and emotionally prepared. Every patient with amputation develops depression universally. And to prepare for that, as well as knowing what is coming, is good practice. We need the support, and the difference to amputees, whether they've got support in place or not, is paramount. When the likelihood's as good as it can be, and then don't hesitate, you get on with it. We really cannot do anything apart from stick to principles, and the general rule worldwide is that you should preserve as much as you can, but be reasonable. Don't do it and then find the wounds don't survive and you need to re-amputate. You should avoid amputation if you've got a joint contracture. And the vascular surgeons amongst you will know that the elderly smokers will sit there with their knees bent for a month or two before they come to us, and doing a below knee amputation with a knee contracture is a waste of time largely. We need to give clearance to allow prosthetic placement. So actually in the modern world, and I'll come to it in a second, we sometimes lose an inch or two to allow the prosthesis And you should do amputations that you can do. Don't think there's 30 amputations in the book, therefore I'll save an inch of leg by doing one I'm not familiar with. And in the UK, the dominant amputation now is the below knee amputation. And the reason it's dominant is because of this, that in good patients, the performance is so good. That interval between the stump and the foot allows a little bit of engineering to go on, which can't be done, say, from a through ankle implant. And so if you look at the amount of energy which is expended walking a set distance or running a set distance, actually a below knee amputee is more efficient than a partial foot or a through ankle amputee, and certainly much more efficient than an above knee amputee. And so the below knee is the mainstay of our practice. It can't be overstated how important it is to have the multidisciplinary team. You've got to work with your limb fitting team, including the prosthetist, the limb fitting surgeon, a psychiatrist, a pain relief surgeon, physiotherapists, occupational therapists, and you are part of that team. When you're looking at the patient, you need to take account of many factors. One of them is the affected limb, how vascular it is, because the time to revascularize is before the amputation, not afterwards. It's sensation. You don't need full sensation, but complete loss of sensation in a stump increases risks. You need to know whether the patient sweats a lot, what their hair is like. If you've got short curly hairs all over your body, you're going to have more problems with your socket fit afterwards than if you don't have the hair there. And you need to look at the unaffected limb and the rest of the patient, and then you need to act on them. So before we go ahead with surgery, we need to examine the limb, we do routine examinations, and we, in particular, look at the vascular supply. The time to get the vascular supply so that you get good wound healing in your amputation stump is prior to amputation. And here we see a couple of cases where either through angioplasty or through bypass, the limb could be improved. So what do you need to get a successful amputation? Well, it helps to have the right patient, but we don't often have the choice of that. It's really good to prepare well, to examine well. It's good to be the right surgeon. And if you're not doing a fair number of amputations, go to someone who is. You've got to choose the right level and you've got to operate at the right time. You may wonder what the picture on the right is. Well, it was in the newspaper about a month ago, and the surgeons kept prevaricating for this chap who has frostbite. What he's done is stuck the toe that he amputated himself with a pair of pliers back in place for the picture. So there's a right time, and the right time is timely operation, and it affects the incidence of post-operative pain, of phantom pain, and other problems, not to leave it too long. You've got to operate well, and you've got to do it in the presence of support services. So let's look at a few principles before we start the guided tour. In any amputation, the skin's got to be healthy, it's got to be durable. And in the foot and the ankle, that means you turn plantar flaps or the back of the calf upwards as a general rule. It's best to be well vascularized, otherwise it won't heal. As you can see it in the lower picture, it's got to be sensate to an extent, but clearly it doesn't have to be completely sensate. And there are some amputations where it's a bit of an advantage, mainly the signs, to be semi-sensate. It's got to be repaired without tension. If it's under tension, you've either cut the bone too low or you've not made your flaps big enough. And plantar flaps, plantar flaps, plantar flaps. The next thing is the muscle. The muscle's got to be debulked, and this applies particularly to the below knee amputation. The picture on the right is a travesty. There is no way, even with shrinkage, that anyone's ever going to put a prosthesis on that. And it needs to be debulked, and it needs to be inserted, as we can see at the bottom, either by bringing the tendinous part of the gastrocnemius soleus up to fascia here, or inserting it at the front of the bone, not to the back here. You're going to come across blood vessels. Small blood, sorry, we're going to talk about nerves first. Nerves are divided high, blood vessels are divided low. So you dissect out the nerves, you pull them down, and you transect them. If you're dealing with a true arteriopath, you may find that the main blood supply to the leg, particularly in above knee amputations, is actually along the sciatic nerve, in which case you may have to diathermy it as well. But in general, pull nerves down, dissect them high. Blood vessels, cautery is fine for small vessels, sutures for large vessels, and if they're sclerotic vessels, arteriosclerotic vessels, transfix them so that your sutures don't pull off. Finally, with the bone, round off the bone edges, avoid spreading bone dusts. This looks like a medieval torture instrument. It's actually pretty useful. It's an amputation guard. And most hospitals have got one hidden somewhere, if only in the museum. If you haven't got one, protect the surrounding soft tissues with a swab. Sorry, my fault. Protect the surrounding tissues with a swab. Don't let your bone dust get into the muscle. Otherwise, it's one of those situations where bone graft will take. We spend half our life wanting bone graft to take and it doesn't, and the other half the other way around. But on this occasion, it will take when you don't want it to. So a quick whirlwind tour of the foot. And my approach to giving you this is to give more emphasis to the amputations you're likely to do and likely to have to do without a senior colleague. In the great toe, the Symes amputation of the great toe, as opposed to through the ankle, comprises a hemiphalanectomy, rotating a plantar flap and removing the nail bed, always please, otherwise it regrows into the wound, and turning it over. When I was a registrar, this was the standard treatment for ingrown toenails. Happily that stopped, but it's still a useful thing for terminal ulcers. Alternatively, if you need to lose more of the big toe, then go either through the IP joint or through the distal part of the proximal phalanx. Preserve that stump. Keep your plantar flap longer than your dorsal flap. You'll hear me say this over and over again. Attach your tendons and you'll keep a push off, and you'll keep the position of the sesamoids right and avoid imbalancing the weight distribution through the foot. And this is just a curiosity. The prosthesis for a big toe amputation, I've never actually seen one, but I found an advert for it, gives a perfect cosmetic toe. The lesser toes, you may amputate them distally or proximally. If you can do it safely distally, do it, because here you see why. It stops the toes from drifting together. Otherwise, the big toe will come across, the third toe will come across, and the nails will dig into the pulp of the opposite one. Plantar flaps, racket incisions, all work. They've all got to be without tension. What you must not do is this, and this is the picture that appears in lots of surgical textbooks, a racket around the base of the toe here, as opposed to 2 or 3 millimeters up. If you take that incision, you will be stretching the tissues across and you'll get a painful and breaking open wound. Whereas this wound will heal very quickly and without problems. It's astonishing the difference. And this is what you get, a little cup of skin at worst, which heals well. And again, see what's happening. that when the patient's walking, that second toenail is going into the side of the big toe. And here's another case, a fourth toe, and this is the reason why you keep a bit of the phalanx, if it's reasonable to do so, is because toes do drift. You could prevent drift, and the second tip about this is if you're amputating 2 toes, the risk's pretty high. Don't amputate more than 2 toes, go for a higher level. You may choose to amputate the big toe or the little toe through the metatarsal. It gives a nice looking foot which fits the shoe nicely, as well as removing the offending tissues. You can do the same thing in the middle with a ray amputation. Here's a picture of a patient who's had a ray amputation. It avoids many of the issues of drift, and it's cosmetically good. The wounds heal well. And this is why you don't amputate multiple toes. This is an old-fashioned operation for rheumatoid arthritis. It's not actually as bad as you think, but you've got to put up with the cosmetics and the aesthetics of it. So this is called the Pobble Operation. Edward Lear wrote a poem about the pobble, which was a creature that had no toes. And it's an amputation through the metatarsophalangeal joints of all the toes. You have to trim off the bunion, you have to trim off any bunionette, and you have to take off the undersurface of the metatarsal heads. You keep a long plantar flap, you'll be surprised to know, and it will heal across the top. And at the tip, you've got thick skin, which is protective. It's pain-free, it fits in a shoe, but it may need a spacer at the front. Above that, the transmetatarsal incisions, again with a plantar flap, again with no tension. And again, you can put a spacer and wear a shoe with this. And this is a spacer for a higher transmetatarsal, and this is a cosmetic prosthesis for that. And either of those can be worn without dysfunction. As you move up towards the midfoot, then you start to get bigger issues because you produce a more bulbous stump, difficult to contain in the shoe, and with a bigger space. But it is performed on a couple of occasions. It's either done as a high transmetatarsal division or as a Lis Frank one, a disarticulation, keeping the base of the fifth metatarsal so you keep peroneus brevis attached to keep the muscles going. They're not bad amputations. People do well with them on one side, and it keeps the length of the leg. It means that the elderly can stomp around on a stump, but it's a little bit non-cosmetic. As you move back in the leg, you go to the show part. I know there's others as well. I'm not going to list every single one, but as you move back into the tarsus, the important thing is that as you remove the navicular and surround, you're going to remove tibialis anterior. So again, long plantar flaps, but take your tibialis anterior and balance your muscle power. So take it through the talus back onto itself so you have a dorsiflexion action as well. Often performed with a fractional lengthening of the Achilles to try and balance that muscle out and to correct any contracture which has happened. The prostheses can be like this, but patients can't push off well with a large foot prosthesis and they tend to walk out of the shoe, and you tend to get a bulky, rather stiff prosthesis from the hindfoot amputations. Then we move to the ankle. The Symes, I'm going to lead you through a Symes amputation. There's 2 modifications of it. One is the Boyd modification, where you take the heel and you implant it up onto the base of the tibia. It gives you a slightly longer implant. You can imagine it's not often these days when you're amputating for diabetes and for arteriosclerosis that this is really a sensible risk. Pirogov takes a longer bit, the division being here, and rotating that segment up and onto the tibia. But the Symes is a very common amputation in the underdeveloped world, where the below-knee prostheses are not so good. It's performed with an anterior incision and then a almost vertical incision down to the heel. You expose and you open up the collateral ligaments on each side so that you can dislocate the foot downwards. You get hold of a great big bone spike to bring it down. You clear the calcaneus, you fold it down, and you cut across the lower tibia, taking off both malleoli. And that's being done with a power saw just here. So pulling it forwards and down, dislocating the talus, removing the medial malleolus. Then you're left with the nerves to dissect. And remember the rule, pull the nerve down, take it high, but preserve those medial vessels to keep the flap viable. Finally, you insert the pad of the heel into the bone in some way or another. If you don't do that, you end up with a bulky heel pad that slips and makes the whole thing unstable. You can do it as in here by suturing through the pad and through the bone. Another technique I've seen in the underdeveloped world is to suture it across and drive a Steinman pin through it, which causes fibrosis and holds it in place long term. Here's the end result with a suture into the bone through here, here, and here, as well as the stump. It's put into a cast afterwards to stop you getting a contracture. And it's a good amputation. It's a viable amputation, but the prosthesis is bulky. It's bulky, and that means that it doesn't have good movement at the ankle. And it's bulky in hot countries, which makes it difficult. But it's still commonly performed for foot and ankle trauma in the underdeveloped world. This sort of prosthesis is very easy to make up if you don't have the sophisticated prosthetists and the cost of the engineering available to you. So whisking through, because time is shooting by, the below knee, there are many ways of doing a below knee amputation. I'm going to give a little bit of detail about the long posterior flap technique as shown here and as cut off at the bottom. The important things here are to bevel the tibia, to divide the fibula a little bit higher, and to debulk the muscle here. I love to get an amputation knife, which looks like the family carving knife, insert it here and fill it out. There's always the risk of an odd assistant losing a finger or two in that exercise, but do debulk it, otherwise you will end up like that stump that we saw at the beginning, where the stump is too bulky. Here's the long posterior flap. The importance here of taking away the muscle, tapering the bone here. I'm not a natural surgeon at forming flaps like our plastic colleagues are who are listening. So I tend to, whoops, lost it. I tend to bring it up, repair fascia to fascia, and trim slightly the dog ear that comes, but do not get carried away and bring your dog ear trimming too far back. Really clever surgeons will have marked out the flap perfectly beforehand, and it just is a dream to watch one of those surgeons do it. Most of us will be like me, and you're better off to accept your limitations. But that's a nice flap, not too bulky, tissues under no tension. Much beloved of surgeons who like alternative operations are the posterior anterior skew flaps, more commonly the medial and lateral skew flaps. Some people like them. It's useful to have experience in them because sometimes skin will be damaged, particularly post-trauma. There's never been any series that has shown any advantage to a skew flap as opposed to a long posterior flap. Another variation is co-fusion of the tibia and fibula. Again, some people like it. They've had experience of getting pain from the lower end and from the upper end of the tibiofibular joint. Unfortunately, the incidence of complications of non-union and malunion here are exactly the same incidence as those of getting tibiofibular instability. After this surgery, you can't overemphasize that this stump will get swollen. So good stump bandaging applied in theatre. I will apply a cast to prevent contracture over this. Early prosthetics, so in the underdeveloped country, we see casts being built into pylons and physiotherapy starting early and mobilizing the patients, preventing contracture, preventing the complications of immobility. The below-knee amputation has high function to it. This chap's, who I know, pictured just having run his marathon. He couldn't, in fairness, walk for about a week afterwards, but it would be more than a week if I ever ran a marathon. This is Paul McCartney's ex-wife, who was a fantasist, but believed she could enter the Winter Olympics. And these are the blades, much beloved, giving good function. And this gap between the bottom of the stump and the ankle allows for engineering to be built in here that gives a near normal gait. You must work in teams. The teams are big. There's no place for the solitary impresario. Sorry, can you see me still?
You stopped your screen share.
Okay, let's get back to screen share. I'm having an issue with getting back to screen share, so we would need to go to here, share my screen and come back in. Sorry about that. Be aware of the risks. The risks are of flap breakdown, usually because you haven't assessed the vascularity well, but sometimes due to infection. Of developing contracture after the amputation, and of residual or phantom pain. And this is a real nuisance. People do still feel their limbs. A lot of people feel their limbs almost universally after a below knee for a period of time. But the Army studied all its amputations, and there is a correlation between how long you have had pain and how much pain you will get after amputation. So those patients who lost their legs traumatically, of which there were a huge number, got very little phantom pain and neuroma formation, compared with those who went on to get problems. I'm going to come to an end there. We've overrun by a few minutes. I've got a slide here of amputation in children. If people want, do you want me to go on for one more minute about it?
That would be wonderful, Paul. Take your time.
Okay. There are particular problems in amputations in children. You want to preserve a length of stump. You want to preserve growth plates. You must tether muscles between them. And if you don't, you will get bone growing through them. They tolerate skin grafts much better, and they do rather well if you do it in young children. But the really big problem is not neuromas, phantom pains like in adults, but the incidence of terminal overgrowth and bones sticking through. There's just one more little subject I'd like to mention, and that is after trauma, what do you do if you end up with a very short stump? And this happened a lot with the patients at Headley Court who had acute amputations, often bilateral. They wanted to keep the mobility as much as possible. It is possible to do stump lengthening within the Lizaroff frame. So get your skin closure, keep a little bit of stump, even if it's too short, and then get someone who is used to doing it to apply a fixator and slowly stretch the stump out 2, 3, 4 or more months down the line. We're there.
Paul, that was brilliant. Thank you very much indeed. It's quite remarkable, isn't it? How you've got to really select the right patient, the right amputation, have the right team around you. There's a lot of things got to line up. And you've got to have a sensational team around you, which you're just a part of it, I think it's fair to say.
Yeah.
Questions are coming in. If you don't mind taking a few, that'd be very kind. The first question is, in acute severe trauma, are there any parameters you would use when deciding whether to salvage a limb versus primary amputation or trying for secondary amputation?
It depends on the circumstances. It depends on the viability of the patient and on the viability of the tissues. If you've got a sensate vascularized foot, then you don't lose much by putting a frame on and reassessing when you've got expert plastics, orthoplastic teams to make that assessment. If you really have not got a sensate vascularized lower leg, then you're probably better off terminalizing at the time. But the patient has a say in this as well, of course.
All about the consent, but that functional foot is a useful foot, as you were saying at the beginning. There's a gentleman here, Christopher Mitchell, writes, "Hi, great presentation. I worked as a prosthetist in Australia for a number of years before moving to the UK and are now an ST6 and SPR. My questions: what are your thoughts on using plaster or rigid immobilization dressings immediately after an amputation?"
Well, I think you've got to be careful. If the sensation's decreased, you've got to be careful. But plaster does help to prevent contracture, and depending on how you are going to use early prosthetics, and I don't mean the definitive prosthetics, but a pneumatic prosthetic or a pylon prosthetic, I think they're helpful in getting that patient up and going. But I'd be happy to be corrected by someone who's a prosthetist, because actually what happens is that you do your amputation, you refer them to you've already referred to them to the limb management team led by the prosthetist often, and they're the people who look after it at that point.
He asks a second very pertinent question, actually. And what was your experience, or what is your experience with the prosthetics available in the NHS, in the military? And do you change your technique of amputation or what you do accordingly?
No is the answer to do you choose your amputation according to it. The prosthetics, if you are prepared and have available huge amounts of money, are better. The military patients, you'll remember, we're all fans of David Cameron, aren't we? And he promised them all that they would get the best of care. And actually, Headley Court's moved from Headley Court now up to the Midlands. But if any of you are interested in this subject, it's worth getting hold of Rodri Phillips, who's the rehab foot and ankle man there. He's not a surgeon, he's a rehabilitation physician, and organising a visit. It's not just the prosthetic, but the prosthetic. Often these people have multiple prostheses. So they'll have a swimming prosthesis, they'll have a wet prosthesis for taking a shower, they'll have one or two normal function prostheses, they'll have a blade for running, they'll have a load of them. And the engineering that can be built in is better than you get through the NHS. Now, unfortunately, we tend to judge the NHS according to what we see. And what we see is often that prosthesis which is put under the amputated leg of a severe diabetic whose expectation or your hope is to get them from their chair to the toilet without using a wheelchair. And there is no point in spending tens of thousands of pounds on that prosthesis. It's a matter of, you know, if you're going to have an amputation, be rich. That's it's a good rule generally, if you can. I don't know how you achieve this. I've left it a bit late, but you will get, there are better ones than through the NHS. The NHS prostheses are not bad. And what we don't have is people who can't afford that level. So we're really lucky in that respect.
Very true. A couple of other questions here. A gentleman called Kamran Khan, who's one of our vascular surgery trainees. Do you see any role for nerve infusion catheters in the stump for post-op pain relief?
Yeah, they come in and out of vogue, don't they? Yes is the answer. The studies which have been done have shown that an indwelling epidural for 24 hours around an amputation reduces the level of pain over the next few weeks, and probably long-term pain if that's invoked at that point. There's less strong evidence about infusion catheters. My own experience of infusion catheters never been particularly brilliant. I just watch a lot of local anaesthetic coming out of the wound frequently. It works its way down. It's not a waterproof system, but there are people who swear by it. It's not a bad technique to, if you're going to use an infusion catheter, to, when you're holding the nerve and you're pulling it down, to take an epidural needle and pass it in to out, so that you can pass your catheter up and along the nerve and out through the proximal skin. So that's something I learned relatively later on, and that stops some of the leakage you get. And probably, if you're going to use the technique, you've also got to have a pump, and you've got to have nurses on the ward who are happy to do that. It's an unusual technique in an orthopaedic ward. It may not be quite so unusual on a vascular ward, I'm sorry to say. But I think good analgesia, by whatever means, is fundamental in the post-operative period.
A few more questions on the more surgical side. With your disarticulations in principle, do you always remove the cartilage, or do you always leave it, or a combination?
Nobody knows. What you need to do is to make sure that you do not get a stump that is moving and sliding on it. So you can leave it, but you've got to adhere the stump. So you've got to do a myodesis across the end of it firmly, with a non-bulky stump, or if you've got a slightly more bulky stump because of position, you've got to some way tether it. That's more important than whether you've got cartilage or bone at the end. It's a bit of 6 to 1, half a dozen of the other.
A question here from Siddhartha Sinha. Oh, it's just gone. Would you, I'm going to try and remember it, but would you usually prefer to do a through knee amputation or an above knee amputation? Extensions, Gritty, Stokes as well.
Yeah, again, we better just define what we're talking about. An above knee amputation, I haven't talked about it because it's not the lower leg, but I've done plenty in my time. It's a pretty disabling operation. You can make it less disabling if you want to go into things like implanted osseous pegs, so that you can put a lighter prosthesis more rigidly fixed into it. They've got disadvantages, of course, because they're great if they work and you don't get infection. They work particularly well in dogs who don't seem to get periprosthetic infections anyhow, even with hip replacements and things. But they're a different group of patients on the whole. The Gritty Stokes, just for anyone who's not familiar with it, is when you do a disarticulation at the knee, you chop off the lower femoral condyles, you chop off the back of the patella, you rotate it round and fix it. So you've got the patella underneath the lower femur. You get more leverage and possibly more power from it. You have a very bulky prosthesis, which tends to hit your other leg and to be bulky. And it's not a massive issue in orthopedics, really. We don't do a lot of them. That's the other problem with it. I did plenty when I was a vascular surgeon. You probably, if you've got a bad arteriosclerotic who's probably going to have angina and not do much anyhow, get slightly more stability in a wheelchair with a through knee, and you certainly get more stability in a wheelchair or a chair if you're doing bilateral surgery, which is not unheard of in these patients.
Interesting question here. When you're having the conversation with the patient pre-op, what's your experience with the kind of time frame from amputation through to prosthesis fitting and rehabilitation?
Well, there's the main thing I'd say there is it's not me that has that conversation. I always will send the patient to the prosthetist beforehand. It's just a universal rule. The prosthetist, the limb fitting physician or surgeon, who actually in our hospital in Oxford was a psychiatrist and still does acute psychiatry, which is a really useful combination, is the person who should be dealing with that. I have my own feelings, but they're going to be the people doing it, and they should be the people who lead the patients through that process. It's a really unusual orthopedic operation because we do say goodbye to the patient around the time of surgery, hopefully, provided they don't start getting neuromas or bone overgrowth and then come back to us.
There's a couple of questions here about management of the wound. So do you use incisional vac application or any tips or tricks for wound closure to try and optimize healing? Tincture of benzene was a favorite of mine.
Yeah, I think the management of the wound is principally having the right, well vascularized flap, which is repaired not under tension. And if you do that, your wound is going to heal. It's 6 of one, half a dozen of another, whether you apply a vacuum suction beneath it. My experience is that if you let the tourniquet down during the operation, you don't actually get a huge amount of bleeding anyhow. It's never been a major issue for me having hematomas from this sort of surgery. If you get a wound breakdown, external vac dressings can be quite useful, but you've got to be really careful and really sound in your mind that you've done the right amputation and that breakdown hasn't happened because it's avascular, because there's a danger that you'll actually make it worse.
A gentleman called David Antibi asks, has hyperbaric oxygen treatment a role in amputation's flap health?
Not in Oxford. Again, I think it might have a small role. You've got to be near a hyperbaric unit. Oxford is about as far from the sea as you can get, and almost all of our hyperbaric units are near the sea. Not quite, but all the medical ones are. You are so close to the threshold of whether it's going to work or not if you need hyperbaric oxygen. I would think harder. I would rather go to the vascular surgeon beforehand and get the vascularity right, or to the vascular radiologists and get the vascularity right beforehand than rely on hyperbaric oxygen. I think if you're going to rely on it, you're in danger there, really.
There's a lot of questions around the kind of management of the actual wound and the turd. There's another one here about whether you would leave a drain in your below knee stumps.
Right, well, I did allude to that. I have done, and I'm not quite sure why I decide when to and when not to. I do let the tourniquet down so as not to have major vessels, because a drain's not the answer to a bleeding major vessel. Correct hemostasis is the answer to that. I've done it. I stopped doing it a few years back, and I've never had an issue with a major hematoma afterwards. The first time that happened to me, I would probably revert to putting one in.
What about if you've got wound problems or something like that, where you think about skin grafting over a stump? Any problems with that?
The main issue, you can skin graft. You can do rotation flaps. I can't do a rotation flap. That's part of the skills of a different group of surgeons, but you can do skin grafts. You've got to be careful where the skin graft is. You can't do it on a point where there's like to be friction from a socket. The biggest issue I've seen lots of skin grafts put on either as a temporary measure to cover and then rotate or stretch tissues across. Biggest issue seems to come from where you take your skin graft. And you've got to be really careful not to take it from the thigh just above the knee where there may be some socket contact on it, because it can throw everything for the rehabilitation.
That leads on quite nicely to a question here from Parasadi Gajula. Have you any experience with dealing with painful stump neuromas?
Yeah, tons.
It's an insightful question.
Of course I haven't. If you do amputations, you will get painful neuromas. The best thing to do is to avoid them as much as you can. So high division of your major nerves, it may not stop neuroma formation, it may not stop phantom pain, but at least it stops it being near the end where you're putting weights through your neuroma. Usually they're dealt with by the physiotherapists, by the prosthetists, by treating the symptoms first, unless that fails. So various modalities of desensitization, of percussion, and so on, and of course drug medications first. The problem with exploring for them is you cut one neuroma out and 3 months later you get another one. We've all, I'm sure you've been there, haven't you, Tim?
Yes. It's very difficult, isn't it? And it's unpredictable who's going to get them and where they're going to get them.
Yeah.
Yes. Now, it's slightly an advanced one. A gentleman called Christopher Wern asks about whether you had any experience in your time with osseointegration, and what you mentioned it, alluded to it earlier, but whether you'd seen it in the lower leg, in the below knee, or anywhere else.
Yeah, I've seen it more in the bilateral above knees in young people, particularly those who've also lost their dominant upper limb. So there were a huge number of multiple amputations came out of Afghanistan. You do need, particularly with an above knee amputation, a certain amount of dexterity to apply the stump. It's much less for a below knee in that you can slip into it, but you still need a certain amount to unroll the socks, the liners, etc. And it is more efficient to have an osseo-integrated peg and an implant that will fix onto it. It works really well when it works, and when you get infection, which is where I have seen it, because the ones that have worked, that have gone off to units where they've had the implants done, and it should only be done in a few units who are used to it, and that work, the most you see is them on the television, performing at the Invictus Games or whatever. When it doesn't work, then of course it's a problem of deep bone infection in a stump.
That leads on quite nicely, in a way, just to reiterate a point about the psychology behind it and how preparation for patients getting ready in that part of the team. Do you use commonly a psychologist, a psychiatrist in preparation? Well,
I always have in Oxford, because our limb fitting surgeon is a psychiatrist in background, and it's an enormous help. He sits down, he goes over the whole lot with the patient beforehand. He explains the depression, the anxieties, the difficulties they're going to have. It's almost, there's something wrong with you if you're not depressed and your body is, you don't have body image problems for some part after an amputation. But he also will deal with the likely issues with partners. Relationships break down because the partner may find an amputation repugnant. And it's really important, because this probably has a bigger impact on the life of the amputee than the surgeon does, as long as he doesn't make a really cack-handed job of it.
I think on that note, I think we can call the questions a day. And I would like to just say thank you very much again indeed for taking your time out and presenting tonight's Lecture of Distinction, the final one in our series. Thank you very much indeed, Paul.
No, it's a pleasure. Thank you. And thank you all for listening. I was just praying that Boris didn't open the pubs last night. Otherwise, we have over 100 people listening in, which is really great, but I think we'd have had none if the pubs had been open. So thank you all for listening. We've only just been able to touch the tip of the iceberg, I'm afraid.
Brilliant. Well, look, There we are. That is the last in our series of the Lectures of Distinction for this year. It's been 6 months and 28 lectures, and I hopefully you've enjoyed joining us, and they're all available still on the YouTube channel. They will be there for a long time to come yet. We're going to start a new series again with some updates and further topics, which will be starting in September this year. So in your feedback, if you come up with ideas of things you would like covered, any obvious things you see that we could improve on, please do give us your feedback, because we really do try and respond to it. Finally, it would not be right for me to not mention a few thank yous at this stage. And in the background, I've been working an IT team from BOFAS, led by Rob Clayton and Karen and Matt and Shalane, who've been brilliant and very, very helpful. And there's a gentleman, one of the registrars and now fellows in foot and ankle, called Yazagani, whose idea it was to come to BOFAS and ask for this. And so really a big thanks to him for coming up with the idea and making this really happen. He's been working in the background throughout as well. And there's one young lady, too, who without this it wouldn't happen, and that is Jo Millard from BOFAS, lead coordinator and PA and everything that we all work for. So thank you to everybody. And it finally just really is for me just to say good night and see you again soon. I hope you've enjoyed it. Take care. Bye-bye.